This is Bettina Yang, group leader of Group 10 from Section C. We are doing our OB video, and we are here to discuss the management options for preterm birth with intact and ruptured membrane. Hope you guys like it.
Philippine Standard Time, 7:20 in the morning.
This time check is brought to you by Trust Condom, bringing you trust on every thrust.
Bringing you information as bright as the sun.
DZ
OLFU 107.3 on your radio dial, serving you a sizzling plate of undeniable facts. DZ OLFU, your sunshine radio. DZ OLFU, your sunshine radio. And now, here are your anchors.
Good day, Philippines. Hello, Valenzuela. Today is January 27, 2020. Welcome to your radio program At Your Cervix.
At your cervix.
I am Adeline
And
Villanueva,
I am Jerome Vanguardia,
your stewards of truth.
Here's your blazing headlines for today.
2 women were rushed to the hospital for allegedly the same reason, preterm birth. However, we've just received an update that they actually have different conditions. First on the scene is our news reporter, Eileen Viray. Eileen?
Thank you, Adeline. I'm here right now at Fatima University Medical Center, where the 2 women that was brought in just a few minutes earlier were thought to have had the same condition, preterm birth. However, we have received a confirmation that although their conditions were almost the same, they did in fact have 2 different types of preterm birth. Here with us now is Dr. Rosel. Good morning, doctor. Can you tell us what exactly happened to the 2 women?
Okay, good morning, Eileen. And also to all your listeners, what we initially thought was the same case for these 2 women was actually not. They were both preterm births, yes, however their condition varied slightly in that one of the women brought in and had him intact while other had a ruptured membrane.
So, doctor, can you give us a brief explanation of the difference between the 2 conditions?
Oh, of course, you see, when we say that there is preterm birth, it would be defined as the mother going into labor with less than 37 age of gestation. The baby comes early. Now, in the case of first woman brought in, she had preterm birth, but her membrane was still intact, which means that her bag of water has yet to burst, hence the term intact. Now, the second woman brought was also having a preterm birth, but she had already had a ruptured membrane, and her bag of water has burst.
I see, Doc, but would there actually be a difference in the management of this woman when simply because the other had her water broken and the other did not?
Oh, there's really not much significant difference in the actual management of the 2 cases, Eileen. They only differ in some considerations when we're trying to predict when the baby will actually come out, and what we can do to ensure that there will be a safe delivery for both the mother and the baby. We can treat both of these conditions mostly with tocolytics or drugs that help to delay the delivery of the baby.
I'm sorry for interrupting, Doc, but why delay the delivery?
That's a good question. You see, these drugs can help delay the delivery of the baby, and in those few days that the delivery is delayed, the doctors can give the baby more help. Remember that this is preterm birth. Its lungs may not be fully developed yet, wherein we can give glucocorticoids to help it mature, or we can put the mother and the baby under observation in the hospital so that we can monitor for any additional complications that can happen.
Doc, you said that there would be some difference in the management of the 2 cases. What are they?
Well, in the one with the ruptured membrane, we may provide a membrane repair while we delay the onset of delivery. Their management will also be based on the age of gestation of the actual baby we are trying to deliver. Antibiotics may be given to prevent infection, inflammation, sulfate for neuroprotection of the baby. And as I mentioned before, steroids to help with lung maturation.
Okay, thank you.
Now, one of the ways we prevent it is by doing a cervical cerclage, which is also known as a cervical stitch. And this is a treatment for cervical incompetence or insufficiency when the cervix starts to shorten and open too early during a pregnancy, causing either a late miscarriage or preterm birth. Usually, the treatment is done in the first or second trimester of pregnancy, usually in the second trimester or early second trimester, for a woman who has had one or more late miscarriages in the past. Now, the word cerclage means hoop in French, as in the metal hoop that encircles a barrel. The treatment consists of a strong suture sewn into the or around the cervix early in the pregnancy, usually between weeks 12 to 14. Some prefer to do it at weeks between weeks 14 to 18, and then we remove this towards the end of the pregnancy when the greatest risk of miscarriage has passed. The procedure is performed under local anesthesia, usually by way of a spinal block. It is typically performed in an outpatient basis by the obstetrician gynecologist, of course. Now, what are some of the types of cervical cerclage that we can perform? One is prophylactic cerclage to be used in women who have history of recurrent mid-trimester losses and who are diagnosed with cervical insufficiency. We can also do a prophylactic cerclage for women identified during sonographic examination to have a short cervix. And we can also do a rescue cerclage, which is done on an emergency basis or done emergently when cervical incompetence is recognized in women with threatened preterm labor. Now, another way of possibly preventing a preterm birth or a preterm delivery is by giving prophylactic treatment using progestin compounds, and this involves administration of progestins or progesterone to maintain uterine quiescence. And the basis of this is, of course, human parturition involves functional progesterone withdrawal mediated by decreased progesterone activity of progesterone receptors. Now, progesterone levels in most mammals, or of course in humans, fall rapidly before the onset of labor, and this is termed progesterone withdrawal. And this is considered to be a parturition triggering event. During human parturition, however, maternal, fetal, and amniotic fluid progesterone levels remain elevated with no decline. It has been proposed that human parturition involves functional progesterone withdrawal mediated by decreased progesterone activity of progesterone receptors. It follows conceptually that the administration of progesterone to maintain uterine quiescence, of course, may block preterm labor, and this hypothesis has stimulated several studies in the past decades or so. Now, how do we diagnose PPROM or pre-labor premature rupture of membranes? Of course, we do this by history. Okay, so we note a history of vaginal leakage of fluid, either as a continuous stream or as a gush of fluid. And of course, this history of vaginal leakage should prompt us to do a speculum examination to visualize gross vaginal pooling of amniotic fluid. We can confirm also the ruptured membranes by doing either a sonographic examination or an ultrasound to assess amniotic fluid volume, or we can also do pH testing of cervicovaginal fluid, and we will see that there's a slightly alkaline reaction in the litmus paper. Of course, we know that amniotic fluid has a pH of 7.1 to 7.3. Now, how do we manage patients with PPROM? Of course, most clinicians will opt to hospitalize these patients. Okay, so concerns regarding the cost of lengthy hospitalizations are usually moot because most women with ruptured membranes enter labor within a week anyway, and they deliver within a week. Now, we have to be wary, of course, of the increased incidence of cord prolapse among these patients. Now, the next step is to give, of course, steroids, to administer steroids in these patients. Now, the National Institutes of Health, or the NIH, in their Consensus Development Conference, recommended a single course of antenatal corticosteroids for women with preterm membrane rupture before 32 weeks and in whom there was no evidence of chorioamnionitis or intraamniotic infection. Now, the ACOG, or the American College of Obstetricians and Gynecologists, recommend single dose therapy or a single dose administration of corticosteroids from age of gestation 24 to 32 weeks. There's no consensus regarding treatment between 32 and 34 weeks, and corticosteroid therapy is not recommended before 24 weeks. Now, we can give either betamethasone or dexamethasone. Now, for the dose of betamethasone, we can give it at 12 milligrams IM for 2 doses every 24 hours. And then for dexamethasone, the dose is 6 milligrams IM every 12 hours for 4 doses. Now, the issue here would be whether to do intentional delivery versus expectant management. Now, some clinicians, of course, will prefer expectant management, and some will prefer intentional delivery. Of course, with intentional delivery, we reduce the length of maternal hospitalization and also reduce infection rates for both the mother and the neonate. The downside to intentional delivery, of course, is that there's higher incidence of neonatal death secondary to pulmonary hypoplasia and sometimes sepsis. Thus, neither management approach proved to be superior for perinatal outcomes. Now, in the end, I guess it will be the prerogative of the obstetrician gynecologist whether to do intentional delivery versus expected management. But usually, we base the choice mainly on the clinical scenario, and of course, we also base it on the age of gestation of the fetus or the patient. And very important also in the management of PPROM is to minimize digital or internal examination. Of course, that is to avoid intraamniotic infection. Now, part of the management of PPROM is, of course, to administer antimicrobial therapy. And the benefits of this is, of course, there's a decreased incidence of chorioamnionitis and decreased incidence of fetal or newborn sepsis. And sometimes the pregnancy is more often than not can be prolonged to approximately 7 days or probably less. We can give ampicillin or erythromycin, and we have to avoid coamoxiclav because this drug um, is associated with increased incidence of necrotizing enterocolitis. Now, this is a very nice table showing to us a summary of the recommended management of preterm ruptured membranes. Now, note here that for 34 weeks AOG or more, we proceed to delivery. Okay, usually by induction of labor, and we give or administer Group B strep prophylaxis. For 32 weeks to 33 weeks AOG, the recommendation is expectant management unless fetal pulmonary maturity is already documented. Group B strep prophylaxis is also recommended. Now, for corticosteroids, there's no consensus, as I've already mentioned, but some experts recommend giving corticosteroids at 32 to 33 weeks. Antimicrobials should be given to prolong latency if, of course, there's no contraindications. Now, for 24 to 31 weeks AOG, again, expected management is recommended. We give Group B strep prophylaxis. We give a single course corticosteroid. Well, tocolytics, there's no consensus in giving tocolytics. We give antimicrobials to prolong the latency if there's no contraindication. Now, if the patient is less than 24 weeks AOG, of course, this is a poor prognosis. So we counsel the patient regarding this, and expected management or induction of labor can be done depending on the case or the clinical scenario. Group B strep is not recommended. Corticosteroids, of course, is not recommended before 24 weeks, and antimicrobials is recommended also. And although there are incomplete data on the use of this in prolonging latency.
Thank you, Arlene and Dr. Roselle.
You know what, partner? This is a very interesting and very complicated subject matter about the ruptured membrane.
Yes, and Dr. Rizal explained it very well.
Yes.
Unfortunately, that's all the time we have for today. This has been me, Edeline Villanueva.
And I am Jerome Vanguardia.
DZ
OLFU
OLFU 107.3 at your cervix.
At your cervix.
This program is brought to you by Robust.
Pare, may problema ako.
Yan.
Nakakayaman, pero alam mo naman tayo, di ba? Pag habang tumatanda, medyo nawawala na ng lakas. Parang hirap na pare.
Problema ba kay Mrs. yan? O...
Oo, nakakayaman pero pre, parang bilis na.
Pare, alam kong sagot dyan. Okay. Tingnan mo.
Ano to pare?
Robust.
Para saan to?
Robust, dietary supplement for men. Sabi nila, ang tunay na lalaki ay matibay, magaling at matigas. Samahan mo pa ng Robust. Robust, para sa mga kalalakihan.
Astig to!
Astig to!
Astig to!